This is Dr. NEENA. She is a senior consultant and head of the department, Pediatric Ophthalmology and Neuro-Ophthalmology, Giridhara Institute, Kochi. She is going to talk about optic neuritis newer developments. Over to you, NEENA.
Thank you, Dr. Kalai, for this opportunity. Thank you, KSOS. So, without much introduction, I'll just directly go into the topic. We know that the optic neuritis, there has been a lot of changes, basically because there has been a revision of the diagnostic criteria. There has been discovery of newer antibodies, basically the anti-aquaporin 4 and anti-myelin oligodendrocyte associated glycoprotein antibody. There has been an availability of newer investigations, and we have new development of immunosuppressants and monoclonal antibodies. So all this has improved our understanding of optic neuritis and associated diseases. So this is a basic classification of optic neuritis. You can classify it as a typical or atypical. Typical would be associated with demyelination when it is associated with MS or isolated. Atypical would be if it is associated with inflammatory or infectious conditions or other cases. So these are the common infectious causes of optic neuritis. The atypical ones are the ones we need to really look out for. It can be associated any of these NMO, MOG. I'll come to each of this later. So what is a typical optic neuritis? We know that that's an inflammatory demyelinating condition, usually affecting a young patient, usually a female with painful loss of vision, most commonly presenting as a retrobulbar neuritis. And the literature says Caucasians and people living in the higher latitudes and temperate climates are more affected, and demyelination associated with MS is the most commonly reported cause in the Western world. So these are some terminologies you should be aware of. One is isolated optic neuritis. Second one is relapsing isolated optic neuritis, chronic relapsing inflammatory optic neuropathy, MS-associated optic neuritis, neuromyelitis optica associated optic neuritis, and myelin oligodendrocyte antibody-associated optic neuritis, because each of them are different in their own way. So what's prevalent in the Asian scenario is quite different from what is reported in the Western literature. We have more of NMO and MOG-associated optic neuritis here, with more of papillitis rather than retrobulbar neuritis. So we will come to that later. So these are the red flags which would tell you which is not a typical optic neuritis and which is an atypical optic neuritis. Now, the importance of MS, I'm not going into detail. Everybody knows that 20% of the MS patients can have optic neuritis as their first episode of demyelination, and 50% of the MS patients will develop optic neuritis during the course of disease. But the funny thing is that the revised 2017 McDonald's criteria does not have any does not have the MRI lesions in the optic nerve as one of the diagnostic criteria. So optic neuritis is not included as one of the diagnostic criteria for MS. So these are the common neuroimaging findings. I'll just skip it due to lack of time. Let's go to neuromyelitis optica spectrum disease. Now, this is something which we are understanding better and better day by day. So what we understand is that this is a most severe form of demyelinating optic neuritis associated with an antibody known as anti-aquaporin P4 antibody. If it is positive, we say it is seropositive NMO spectrum disease. If it's negative, it is seronegative NMO spectrum disease. So this is associated with frequent relapses, poor vision, very profound vision loss, and the recovery is also not very good, often associated with transverse myelitis, bilateral involvement. So the left-hand side shows you the MRI pictures with swelling and enhancement of the right optic nerve, and it could be a long optic nerve involvement. Even the chasm could be involved. So what basically happens is aquaporin P4 is a water channel which is present at the foot process of the astrocytes, which facilitates water movement across the cell membrane. So when there is an antibody to that, there is a complement activation, damage to the astrocytes, there is demyelination. That is how the whole pathway gets activated. So coming to the other entity, which is the MOGAD or the anti-MOG associated disease, in which there is antibodies which are against the MOG, that is the myelin oligodendrocyte glycoprotein, which is a glycoprotein located on the oligodendrocyte and myelin sheath, which is again important for the functioning of the whole process, and there is demyelination in that antibody-antigen reaction. So what is different in anti-MOG disease? Here, the age group is little different. So the MS patients are typically 20 to 40 years. MOG usually affects the age of 31 to 37 years. More or less similar male-female, whereas the MS affects females more. Here again, there is more of disc edema or papillitis-like presentation rather than a retrobulbar neuritis presentation. And the important thing is that they have excellent visual prognosis with steroids. However, the recurrence are quite high. Okay, and in children, this is one of the most common causes of optic neuritis, and it causes up to 50% of acute demyelinating events in children. And MRI shows this characteristic optic nerve enhancement. Sometimes even the perineural enhancement or the nerve sheath enhancement is thought to be very typical of MOG disease. So this is a beautiful table which I've taken from Saxena et al.'s article in IJO, which compares the various different types of optic neuritis, MS optic neuritis, anti-evaporin optic neuritis, and MOG optic neuritis. So a newer entity called glial fibrillary acidic protein IgG astrocytopathy has been described, and the antibodies are apparently detected in some patients, though it has, I don't know whether it is, we are doing it here in India. Now, another important entity is CRION, or chronic relapsing inflammatory optic neuropathy. It presents like a typical optic neuritis, responds beautifully to steroids. The minute you stop the steroids, it recurs. And you have to put the patient again on steroids. You stop again, it recurs. So eventually you will have to maintain the patient on long-term steroid therapy and eventually on immunosuppressants. I had one patient who had bilateral hip fractures because of the chronic steroid therapy, and she had to be put on azathioprine eventually. So it has a long course, but it responds well. COVID-19 saw the onset of variable types of optic neuritis associated with the disease as well as with vaccinations. We are all familiar with that. Pediatric optic neuritis. We know that pediatric optic neuritis is a little different from the typical optic neuritis we see in the adult population. We have more of papillitis-like presentation, more of bilateral presentations, and the vision loss is more pronounced in pediatric cases, with more than 50% of the children presenting with very poor vision at presentation. And MOG is supposed to be the most common cause. At least in India, we find that MOG is the most common cause of optic neuritis in children. And some of them may even progress to acute demyelinating events. So that is, they also have higher relapse rates, but they respond very well. So how do we approach? This is a typical working pattern of an optic neuritis. So we give IV methylprednisolone according to the weight for all the patients. Then we definitely send them for a neurology consultations and serology to rule out the MOG and the NMO spectrum and MS if at all. MRI, of course, is done at the initial stage itself, not for diagnosis, but for prognostication. And if the patient does not respond to treatment, then you have to talk to the neurologist and think about whether it's falling into any of the NMO MOG spectrum if the antibodies are positive, and think about considering IVIG or plasmapheresis. And depending on the response, you may have to maintain the patient on steroids for long-term duration or switch over to immunosuppressants. Now, this was an update of optic neuritis where they recommend early intervention if it is atypical, not the one which is typically described in the Western literature. So this is again an approach taken from Saxena et al.'s article from IJO. So nowadays we are doing routinely serology in all cases of optic neuritis because we are getting more and more seropositivity, especially with MOG. So are serological tests is needed? Yes, because we need to know the long-term prognosis of the condition and which test is important. Serum testing is better, cell-based assays are better. And CSF studies is definitely indicated in patients with MS suspicion and also to rule out infections and in some other conditions in which you are suspecting rare cases. So ONTT definitely gave us some gold standards about how to treat optic neuritis patients, and we still follow it. But in Indian patients, we do give IVMP for 5 days, and we do give for a longer duration than the routinely prescribed 11 days. Now, treatment is very different from MS and for NMO and for MOG. So if it is MS, you offer immune prophylaxis after the initial IV steroids. So you have disease-modifying agents like beta-interferons and immunomodulators like glatiramer acetate and dimethylfumarate and fingolimod and monoclonal antibodies. But if it is NMO and NMO spectrum disease, you don't give immune prophylaxis. You put them on immunosuppressants. So that is the difference. So azathioprine, methotrexate, MMF, rituximab, these are the ones which we use. And again, a lot of studies are going on, newer therapies which look at optic nerve regeneration and remyelination. So take-home points would be optic neuritis is the clinical diagnosis. We can all diagnose optic neuritis. MRI is not required for the diagnosis, but it is the most important ancillary test because it can confirm the diagnosis and also prognosticate and rule out the masqueraders. And you should order an MRI brain and orbits with contrast, with flare sequence, and CSF studies. And serology should be done ideally in all cases, suspicious cases, MRI spine, and definitely think about atypical cases when you have atypical findings. Thank you.